So welcome to this touchIME conversation activity. My name is Natalia Rodriguez Gómez-Hidalgo. I'm a gynecologist oncologist from Valdebrón University Hospital in Barcelona from Spain. And today I have the pleasure to interview Professor Nicoletta Colombo. So she's a professor of obstetrics and gynecology from the University of Milano Bicocca, and she is also the director of the Medical Oncology Division from the European Institute of Oncology in Milan, from Italy.
Thank you, Natalia. Very nice to be here with you today.
Today, we are going to talk about maximizing the potential of PARP inhibitors as first-line maintenance therapy in ovarian cancer, with a focus on improving patient identification and treatment selection. In this first session, we will be considering what is the scientific and clinical basis for using PARP inhibitors in the first-line maintenance setting. So the data from randomized clinical trial have established an important role from frontline PARP inhibitors maintenance therapy in ovarian cancer. While solo one study only include BRCA patients, PRIMA, VELIA, and PAOLA-1 enroll broader patient population. The magnitude of benefit of the PARP inhibitors in these studies was greatest in the BRCA mutation patients. PARP inhibitors treatment also improved progression-free survival in the homologous recombination deficiency cohort, but to a lesser degree than in patients with BRCA mutation. In a secondary analysis, the overall impact of PARP inhibitors treatment in the homologous recombination proficient patients, which comprise about 50% of ovarian cancer, was more limited than in the other subgroups. So without maintenance therapy, the progression-free survival shortens with its recurrence in advanced ovarian cancer. Actually, long-term follow-up data on survival benefit with PARP inhibitors maintenance are emerging. With the solo one study, with a 5-year follow-up, the mean median progression-free survival with olaparib treatment was about 56 months, compared to placebo and 15 months. With the ENGO-OV16 study and NOVA study, the mean overall survival with a 6-year follow-up in patients with BRCA mutation and niraparib treatment was about 45 and 9 months versus 43 and 2 months with placebo. And in patients without BRCA mutation and niraparib treatment, the mean overall survival was 38 and 5 months versus 39 and 1 month with placebo. So let's move forward with the first question. It is clear that PARP inhibitors represent an important maintenance treatment option in advanced ovarian cancer, but how do they work and what challenges exist?
Thank you for the nice question. So let me start by explaining how PARP inhibitors work. As you know, each type of DNA damage is repaired by a specific process. And for instance, when we have DNA single-strand breaks, the base excision repair is the mechanism which may repair this break, and this mechanism involves PARP enzymes. On the other hand, when we have a double-strand breaks, then we need a different mechanism of repair, and the most efficient in this situation is the homologous recombination repair. It has been recognized since the publication of the Cancer Genome Atlas that ovarian cancer, specifically high-grade serous ovarian cancer, are characterized by extensive defects in the homologous recombination repair. So for this reason now, high-grade serous ovarian cancer is considered an ideal target for PARP inhibitor. So let's see how PARP work. When we use a PARP inhibitors, we basically block the repair of the single-strand breaks. And the mechanism is due to both enzymatic inhibition of PARP and also a trapping, a mechanism of trapping. So PARP is trapped on the single strand break, and so during the replication, this will lead to a double strand breaks. At this point, we need a very efficient homologous recombination repair. If this is working, then the cells can repair the DNA and will survive. Otherwise, the cells will go into apoptosis. And this is the mechanism of synthetic lethality on which the activity of PARP inhibitors is based.
Thank you, Professor Colombo. The second question is, what are the key clinical trial data supporting the approval of PARP inhibitors in the first-line maintenance setting?
Yeah, Natalia, you mentioned already these incredible data that we had during the past 3-4 years. Starting from SOLO-1, which was published in 2018. SOLO-1 was conducted only in patients with BRCA mutation and really demonstrated an incredible and unprecedented benefit for the use of olaparib in patients with high-grade serous ovarian cancer in response to first-line platinum-based chemotherapy. But after that, in 2019, we had the results of the other 2 trials, the PRIMA and the PAOLA-1, and they also confirm an incredible benefit for patients with BRCA mutation. But not only that, I mean, these trials included all patients, not only patients with BRCA mutation, but also patients with tumor BRCA wild type. And they were able to demonstrate a very important benefit, particularly in those patients or in those tumors with homologous recombination deficiency. This homologous recombination deficiency was detected through a test, a genomic instability test, and both of these trials used the Myriad My Choice. They identified that about half, 50% of the population in these trials in fact presented a homologous recombination deficiency. And for those patients, the benefit with the addition of a maintenance PARP inhibitor, either niraparib in the PRIMA study or olaparib together with bevacizumab in the PAOLA study, was associated with an incredible benefit and a hazard ratio of 0.43 in PAOLA-1 and 0.50 in PRIMA for those patients with a tumor without a BRCA mutation, so BRCA wild type, but with HRD positive test. So these are the patients for whom incredible benefit has been demonstrated. Unfortunately, I think we have to discuss whether the same benefit can be seen also in patients without a positive HRD test. In fact, in this population, what we saw from these trials is that you may have a small benefit in the PRIMA study, about 2.7 months in the median progression-free survival improvement, but not for the PAOLA-1 study. So the combination of olaparib and bevacizumab did not provide a statistically significant benefit for patients without HRD test positive, so with an HRD negative test, in fact. Now, a few days ago, we were at ASCO, and we heard the presentation of the ATHENA study. The ATHENA is a pure maintenance study. Originally included 4 arms. What it was presented at ASCO was just the results for the ATHENA mono, so the combination of rucaparib maintenance versus placebo in patients with ovarian cancer in complete or partial remission to platinum-based chemotherapy. And also the ATHENA study confirmed the efficacy of another PARP inhibitor, rucaparib, in improving progression-free survival. And this was, once again, absolutely clear in patients with HRD positive test. Actually, they use a different test. They check with the LOH. So in patients with LOH high, they saw an improvement with a hazard ratio of 0.47, but also they saw the benefit in the intention to treat population with a hazard ratio of 0.52. So it was confirmed the incredible benefit of using another PARP inhibitor, rucaparib, as maintenance treatment in front line. Also, they looked at subgroups, and they could identify a small benefit even in patients with LOH low tumors. Once again, similar to the PRIMA study, the benefit is in the range of about 3 months in the median progression-free survival, but it was demonstrated an advantage also in this population.
So the third question, PARP inhibitors had been approved for a couple of years now in advanced ovarian cancer. During this time, what new insight into their efficacy and safety in the first-line maintenance setting had been gained from real-world data?
Yeah, also at ASCO, a few days ago, we heard a very interesting presentation. This was in the poster discussion. Basically, they look at real-world effectiveness of first-line maintenance olaparib in women with BRCA mutation. They collected individual physicians' data for stage 3 and 4 ovarian cancer and positive and BRCA mutation, and they saw. They looked at the time to discontinuation of maintenance treatment and the time to first subsequent therapy. So it was very interesting. They collected information from 457 patients with BRCA mutation. And from 2019 until June 2019, post-SOLO-1, so from January 2018 and June 2019, and first of all, they observed that only 36% of patients received a maintenance treatment. And of these, 26% received a PARP inhibitors and 23% received olaparib. And it was very interesting to see that the majority of patients, the median time to discontinuation was 25 months. Remember that olaparib is given for 2 years. So basically, that means that the majority of patients completed the 2 years of treatment. And even more important, at 2 years, the event rate, so the number of progression was actually only 9%. So 91% of patients were alive without progression after 2 years. So of course, this confirmed the extremely positive data that we had already from the SOLO-1 trial.
Let's start with the second session. In this session, we will consider how to identify patients who may benefit from a PARP inhibitor in the first-line maintenance setting. So here we have the ESMO recommendations for a PARP inhibitor therapy. So first, we have to perform a test for somatic and germline BRCA1 or 2 mutation at diagnosis, and for sure, we have to observe a partial or complete response to first-line platinum-based chemotherapy. If the patient has a BRCA mutation, is eligible for PARP inhibitor. And if the patient has a BRCA wild type, we have to perform an HRT testing. If the test comes positive, the patient is eligible for PARP inhibitor. So now let's move forward with the next question. In your clinical practice, how do you determine which patients with advanced ovarian cancer are eligible for first-line PARP inhibitor maintenance therapy?
Yeah, thank you very much for this very important question. I think there are several factors that we should consider. Of course, we learn how important is the genomic biomarker. So we have to understand if the patient has a BRCA mutation, if the tumor has a homologous recombination deficiency or not, and this is the first thing. We may also consider some other clinical characteristics, for instance, the influence of timing and outcome of surgery. So whether the patients underwent primary debulking surgery with residual tumor, without residual tumor, or she underwent a neoadjuvant chemo followed by surgery. Then another important element to identify the best patients for PARP inhibitors is the response to chemotherapy. And of course, we have to take into consideration the quality of life, the acute toxicity, and also the long-term safety of these compounds. So recently, we have designed a kind of algorithm in order to select patients for PARP inhibitors. And so when you have a patient with ovarian cancer, the first thing to do is, for sure, we know now, testing for BRCA, either somatic BRCA or germline BRCA, but we have to know whether there is a mutation or not. Of course, then patients should be selected for primary debulking surgery or neoadjuvant chemotherapy. And then we have to decide whether to add bevacizumab to chemotherapy or not. And this is, of course, a decision we can be related to the presence of contraindications for the use of bevacizumab, if we use neoadjuvant chemo or not, whether this drug is reimbursed. We know that there are differences in the reimbursement across different countries and regions. And maybe we also want to consider the HRD status. So there are several elements to decide. Of course, if the patient receives bevacizumab, then the following maintenance treatment will be decided based on the results of the genomic markers. So in case of BRCA mutation, for sure, she should receive or she should add olaparib to bevacizumab. In case of HRD, the same. In case of negative HRD test, I think the patient should continue on bevacizumab. Now, in the other situation where bevacizumab was not administered together with the chemotherapy, then of course, once again, we have to look at genomic biomarker, and the patient should be treated with PARP inhibitor in case of BRCA mutation and also in case of HRD positive. And it may be discussed also in case of HRD negative test, because of course this patient cannot receive bevacizumab because there are contraindications or other reasons why bevacizumab was not administered.
So the next question, how does biomarker testing guide your choice of PARP inhibitor for first-line maintenance therapy?
Yeah, I think we already emphasized how patients with BRCA mutation can derive unprecedented benefit from PARP inhibitors. And this is very consistent across all the different trials. In SOLO-1, just to remind you, the hazard ratio was 0.33. In PRIMA, for BRCA mutation, was 0.40. And in PAOLA-1 was 0.31. So I think there is no doubts whatsoever that patients with BRCA mutation should be treated with PARP inhibitors, either alone or in combination with bevacizumab. And of course, this also means that all patients should be tested for BRCA at time of diagnosis immediately, as soon as possible. Now, I think the real question in patients with BRCA mutation is whether to use a PARP inhibitor alone or to use the combination with bevacizumab, because as I said, the PAOLA-1 study demonstrated a benefit in this population for the use of bevacizumab plus olaparib compared to bevacizumab alone. But we don't have any prospective data to compare the combination of a PARP inhibitor with bevacizumab versus a PARP inhibitor alone. We do have some indirect comparison, and this is a paper recently published by Ignace Vergote. They try to identify a similar population in PAOLA-1 of patients with BRCA mutation and similar characteristics match compared to the SOLO-1 population. And by this indirect comparison, a benefit was seen, which was not statistically significant, but patients treated in PAOLA-1 seems to derive slightly more benefit compared to patients treated in SOLO-1 with olaparib alone. But of course, this is just an indirect comparison, so I think we cannot conclude anything, and a prospective randomized trial is needed. As I said, besides BRCA mutation, I don't have any doubts that patients with HRD positive tumor should be treated, must be treated with a PARP inhibitor, I would say. And once again, you have the choice between niraparib alone or the combination of bevacizumab and olaparib from PAOLA-1. The benefit is absolutely very important, has a ratio in the range of 0.43. So I don't think we should deny the benefit of a PARP inhibitor in these populations. Of course, we may discuss what to do in patients with BRCA wild type and HRD negative test. The benefit from niraparib is about 2.7 months in median progression-free survival. In PAOLA-1, there was no benefit, unfortunately, in this population. So the question here is whether to consider, again, bevacizumab alone or niraparib in this population. And this, I think, is should be taken into consideration other aspects that are important to consider. For instance, I think their response to chemotherapy is another important element to be considered, because if a patient has an extremely very, very good response to chemotherapy, then this may be an indirect signal of a potential benefit from PARP inhibitors. So let's say a patient with HRD negative tumor, but with an extreme response to PARP, to platinum-based chemotherapy, I would consider the use of niraparib in this patient, even though she is HRD negative. But if you have a suboptimal response to platinum, then probably I would choose bevacizumab.
Thank you, Professor Colombo. So the next question is, what is your approach to shared treatment decision-making? How do you discuss the pros and cons of first-line maintenance therapy with your patients?
Yeah, this is a very important conversation. Of course, our patients, they want to complete chemotherapy and then go on vacation from chemotherapy, on vacation from any treatment. So we have to convince them that they have to receive maintenance therapy. And why? Because we know that ovarian cancer is most of the time a chronic disease. So it is characterized by multiple relapses, and unfortunately the time between each relapse becomes shorter and shorter over time. So it is important to try to achieve the maximum benefit from the frontline treatment, because once the disease relapses, it is largely incurable. And so first-line advanced ovarian cancer is the optimal setting to achieve a potential cure. So that's why I want to convince my patient to explain them that even when they achieve a apparent complete response to chemotherapy, we know that in the majority of cases, there are still some residual tumor. This is the minimal residual disease that we cannot see, we cannot detect. CA125 is negative, CT scan is negative, but we know is there. And of course, if you don't do anything, this tumor will regrow and the patient will have a relapse. So the meaning of a maintenance treatment, which is not only maintenance, actually is curative, we hope, in some cases, is to give a very effective treatment which may eradicate this minimal residual tumor, so to avoid the relapse and hopefully to achieve cure. That is what we want, of course, for our patients.
In this third and final session, we will consider how to select a maintenance treatment regimen for individual patients. Here we have several factors to select the specific patient for maintenance therapy. So first, we have to take into consideration the clinical history and the patient status, like the comorbidities, figure staging, prior treatment, if the patient has or not a recurrence, the treatment-related factors as well, the safety profile of the treatment, convenience, the patient choice, and even the trial eligibility. So we also have to consider molecular pathology and genomics, like the HRD status, the BRCA status, and genomic reversions. And finally, the financial consideration, the approval status, the indication for sure, and even the reimbursement. So for patients with complete or partial response to first-line platinum-based chemotherapy, we have these options. So for olaparib treatment, the regular doses is 300 milligrams taken twice daily, up to 2 years if there is no radiological evidence of disease, and more than 2 years if potential further benefit is another valid option. For niraparib treatment, so we have to consider the weight of the patient. So actually the patient should have a weight more than 77 kilograms and more than 150,000 count platelet. And the starting dose is 300 milligrams once daily. And another valid option is 200 milligrams taken once daily. And finally, the last option is olaparib and bevacizumab, 300 milligrams of olaparib taken twice daily, and 15 milligrams per kilo of bevacizumab once every 3 weeks. So here we have the first question from this session. Which comorbidity would you consider relevant when deciding whether a patient is a candidate for first-line PARP inhibitor maintenance therapy? And we have a case as an example. So a patient with newly diagnosed stage 4 epithelial ovarian cancer with a somatic BRCA1 or 2 mutation, history of mild hypertension, partial remission status after first-line chemotherapy, and identified as a potential candidate for first-line maintenance therapy.
Yeah, if we talk about which patient cannot be candidate for a PARP inhibitor, I think very few of them will not be candidate in terms of, let's say, toxicity. Because as you know, for instance, in this case, we have a patient with stage 4, so very high risk, and she also has a BRCA1 and 2 mutation. So she is absolutely a candidate for the use of PARP inhibitors in the maintenance setting after a complete or partial response, of course, to chemotherapy. Now, of course, we have to make sure that she has recovered from the most important side effects from chemotherapy. Once again, in these patients, one important issue is whether she should be treated also with bevacizumab together with chemotherapy during the first part of her treatment, because she has a higher risk disease. And so I think in most countries, bevacizumab is approved in patients with stage 4 disease or stage 3 with a bulky residual tumor. So I would give consideration to give her also bevacizumab together with chemotherapy for sure. I think the history of mild hypertension is not an absolute contraindication for the use of bevacizumab for sure. If the hypertension is under control, even with medication, I think she should be treated with bevacizumab anyhow. What we have to check, of course, is that she responds to frontline chemotherapy, and then we are all set. So in this case, I think I would consider definitely the use of PARP inhibitor as a maintenance.
Thank you for the clarification. So now, the next question. Having decided to treat the patient with a PARP inhibitor, what factors would you consider when initiating therapy?
Okay, so as I said, I think we have to check carefully the patient. She has to be recovered completely from prior toxicity, first of all, because we have to remember that unfortunately PARP inhibitors are very effective, but also they have some toxicities. And most importantly is, of course, anemia, for instance, which is very frequent with any PARP inhibitor. So a patient should have recovered from severe anemia or severe myelosuppression in general. Also, nausea and vomiting should be under control. And so when we have seen that all these data are okay, then I think we can start. Remember that PARP inhibitor should be started generally. I would recommend in between 8 weeks from the end of chemotherapy. You may consider even a later time, but I will not move further the initiation of treatment. So as soon as the patient is in good shape and she has recovered from toxicity, I would start PARP inhibitors.
The next question. PARP inhibitors show a classified adverse event profile. However, there are some subtle differences between agents. Which adverse events would you actively monitor for in this patient, and how would this monitoring differ based on your choice of PARP inhibitors?
Yeah, as I said before, there are toxicity, there are adverse events. Some of them are really class characteristics. So you can have the same adverse events with any PARP inhibitors that you are using. For instance, nausea and fatigue, asthenia, these are very common, and anemia. Anemia is probably the most severe adverse events that you can observe with the use of PARP inhibitors. And the percentage of anemia is quite similar across different PARP inhibitors. That's why the patient should be checked very, very carefully, particularly during, I would say, the first 3 months, because the side effects are very frequent at the beginning. And so you have to detect these side effects and to monitor very carefully the blood counts in order to identify anemia or thrombocytopenia in the case, of course, of niraparib. And then in this case, you may have to stop treatment and to wait for complete recovery because start again. And you may even consider to reduce the dose in order to continue. So I would say that the occurrence of these side effects, even though sometimes they are quite severe, do not prevent the continuation of treatment. It's just a matter to stop and to try to identify the right dose for each patient. And then you can continue usually, and you can go on for, 2 years in case of olaparib or 3 years in case of niraparib. So the 3 months are crucial, and patients should be advised to check very frequently the blood counts and to report of any severe adverse events, because if we start immediately treatment for these adverse events, then the patient may continue without any further problem. Of course, as I said, there are some differences across the different PARP inhibitors. Thrombocytopenia is very characteristic of niraparib and is very rarely observed with olaparib. There are other differences. For instance, the schedule of administration. For olaparib is twice a day, and for niraparib is just once a day. So this can be more convenient for some patients. Of course, then the other important issue is the interaction with food and with drugs. For niraparib, there are no interaction with food and drugs. For olaparib, we know that it's important to take olaparib at least 2 hours after food, and because this may have an interference with the kinetics of the drug. And also it's important to recognize that patients should not drink grapefruit juice, which may again interfere with the exposure to olaparib and so lead to higher toxicity, and also with some drugs, for instance, dexamethasone, ondansetron, or Zofran, or even probiotics. So I think all these instructions should be given to patients in order to be able to control the side effects and to avoid the severity of some of these side effects.
So thank you very much, Professor Nicoletta Colombo, for such a great discussion and very interesting topic. So I would like to thank to all of you for being here today with us. I hope you enjoyed the discussion and the topic as well, and I hope you find it interesting as well. Thank you.
I'd like to thank you also for being with us today. It has been a great pleasure for me to discuss these very important topics with Dr. Natalia Gómez-Hidalgo.